Obsessive Compulsive Disorder: How to Overcome OCD. Written by Albert Rogers. Narrated by Lee Ashman. Introduction. Do you know what OCD is? Do you know what obsessive compulsive disorder can cause? These are the questions you should ask yourself if someone near you or you is showing signs of this disorder. The problem is that a lot of people either think they have it when they don't, or they think they don't have it when they do. Clinical studies, signs, and symptoms are discussed in this book so you can find out where to draw the line and when to take action. Also, in this compilation of research reports and findings, I want to point out how to help solve the problem through medication, treatment, and psychological therapy. I assure you that you are looking at the right book for understanding, assessing, and handling obsessive-compulsive disorder, and that you will be amazed by some of the discoveries scientists and clinicians have made. Don't wait any longer and listen on. Chapter 1. What is OCD? Before we dive into any strategies or tips to deal with OCD, we need to establish what it is. Obsessive-compulsive disorder is often misunderstood. It's actually pretty common for people to be stuck in a habit they have a hard time breaking. Obsessive-compulsive disorder is an anxiety disorder in which people have unwanted and repeated thoughts, feelings, ideas, sensations, obsessions, or behaviors that make them feel driven to do something, compulsions. Often, the person performs the behavior to eliminate the obsessive ideas, but this only gives him or her temporary relief. Not carrying out these obsessive rituals can cause a lot of anxiety. A person's level of OCD can be anywhere from mild to severe, but if it is severe and doesn't get treated, it can obliterate someone's capacity to function. About 1 in 150 people suffer from this compulsive disorder. Eating disorders, depression, anxiety disorders, and other personality disorders can, in some cases, accompany OCD. The percentage of men and women who have this disorder is about the same. Usually, it already becomes apparent in someone's childhood, and research has pointed out that it is hereditary. Although these symptoms can be visible in one's childhood, studies indicate that most of the symptoms typically begin in the teen years. Treatment and testing are important when such symptoms are observed. As the words indicate, obsessive-compulsive disorder is a disorder that is based on obsessions, which come from fears and anxiety. As a response to these obsessions, an individual will typically perform rituals and repeat the same action over and over again, which is defined as compulsive behavior. The behavior, however, is only a visible result of the root problem. The root is the fears that cause the obsessive thoughts. In the next chapter, we'll elaborate on these obsessions and compulsive acts in more detail. Chapter 2. Symptoms. Which symptoms are typical for someone with obsessive-compulsive disorder? Here is a list of possible symptoms. 1. They have repeated thoughts or images in their heads about several things, like a fear of germs, intruders, hurting others, violence, sexual acts, or being overly neat. 2. They repeat the same behavior over and over again, like locking doors, washing hands, counting, or hoarding. 3. They constantly have undesired thoughts and behaviors that they find hard to control. 4. They do not find pleasure in the rituals or behaviors, but they find a short relief from anxiety if they perform them. 5. They spend an hour or more per day on these thoughts and rituals, which interfere with daily life. 6. Persistent, paranoid, often unrealistic fears. It's hard to reason with them concerning those aspects of their perception of reality. 7. Checking and washing are the most common reported compulsions of OCD. Others have a compulsive tendency to rearrange things, or mentally repeating phrases, or list making. 8. Those with OCD often fear losing control. This doesn't mean that all control freaks have OCD or that all people with OCD are control freaks, but the fear that they might harm someone with their compulsive behavior exists. 9. Religious obsessions occur, like the fear of offending God. 10. Unwanted sexual thoughts, like homosexuality or incest thoughts, could accompany OCD. This doesn't mean that the individuals should be considered a threat, homosexual, pedophilic, or uncontrolled, but it's typical for some with OCD to just have those thoughts bothering them. 11. Perfectionism is often typical to the point that they fret over exactness or a need to remember things or keep track of things. Some people with obsessive compulsive disorder partially or fully understand the uselessness of their obsessiveness and compulsive behaviors, though they find it hard to stop doing it. Others lack a comprehension of their strange thinking patterns and are blinded to the fact that they are overdoing things. A lot of people with OCD are able to keep their obsessive-compulsive symptoms under control when they are working, studying, or feel relaxed enough to function well. Resistance might weaken occasionally, however, especially when they are anxious, when sudden changes in their lives occur, or when they panic inside. It's typical for symptoms to come and go, to become easier to handle or worse. If the symptoms become too terrible, their responsibilities and daily tasks may suffer from the consequences. Another way some people with OCD handle their obsessive-compulsive disorder is by taking alcohol or drugs, which obviously isn't a good solution at all. In the next few chapters, we'll research the disorder's origin in 3 different ways: biological, psychological, and environmental. Chapter 3. Biological causes. The fact that OCD patients react well to particular medications affecting the neurotransmitter serotonin points out that the disorder has a neurobiological basis. The interaction of neurobiological factors, as well as cognitive processes, is the focus in this chapter. Coexisting disorders such as attention deficit disorder or autism can make OCD harder to diagnose and treat. The same is true when a person with OCD suffers from depression, substance abuse, or eating disorders. Symptoms of OCD are seen in association with some other neurological disorders. There is an increased rate of OCD in people with Tourette's syndrome, an illness characterized by involuntary movements and vocalizations. Investigators are currently studying the hypothesis that a genetic relationship exists between OCD and the tic disorders. Other illnesses that may be linked to OCD are trichotillomania, the repeated urge to pull out scalp hair, eyelashes, eyebrows, or other body hair, body dysmorphic disorder, excessive preoccupation with imaginary or exaggerated defects in appearance, and hypochondriasis, the fear of having, despite medical evaluation and reassurance, a serious disease. Researchers are investigating the place of OCD within a spectrum of disorders that may share certain biological or psychological bases. A common misconception is that people who are somewhat compulsive or perfectionists by nature can be classified as having OCD. Many people who show some compulsive or obsessive tendencies, which may be 90% of the population anyway, do not show extreme enough symptoms to be labeled as having a disorder in that sense. Moreover, try to see the value and contribution of being obsessed with a clean or orderly environment or the tendency to perfect things. How many companies could function without their precise accountants? How many surgeons would do a good job if hygiene wasn't one of their most important standards? And how many people would feel at home in a space where nothing was cleaned up or organized? Compulsive behaviors have their place in society, and some of them are highly needed. The problem with those who have OCD lies in the interference with essential rationale and crucial daily tasks. One person's story. One person with OCD said, "As far back as I can remember, my family and friends referred to me as a worrywart. When I was about the age of 16, my experiences with OCD began. I had just started high school and things were stressful with all the changes. A friend of mine had been afflicted with a case of food poisoning, and that was when I acquired my fear of being poisoned. I can still remember how it started as a tiny concern and proceeded to snowball into the major preoccupation of my life. Brain science. OCD is actually caused by a combination of biological, psychological, and environmental components. As far as the biological aspects are concerned, a lack of serotonin, as I mentioned earlier, is the main cause. Serotonin sends neurological messages that transmit signals between brain cells. It plays a role in mood regulation, impulse control, aggression, appetite, sleep, pain, and body temperature. For example, after a visit to the bathroom, you may begin to wash your hands to remove any harmful germs you may have encountered. Once you have performed the appropriate behavior, in this case washing your hands, the impulse from this brain circuit diminishes and you stop washing your hands and go about your day. It has been suggested that if you have OCD, your brain has difficulty turning off or ignoring impulses from this circuit. This, in turn, means the obsessions and compulsions continue, leading you to wash your hands again and again. Studies concerning the various specific areas in the brain show that people with OCD show more unusual activity in 4 interconnected areas in the brain. 1. The caudate nucleus. 2. Specific brain cells in the basal ganglia. 3. The prefrontal orbital cortex. 4. The cingulate gyrus. The first, the caudate nucleus, is considered to be the main part of the brain that regulates repetitive and habitual behaviors. Medicine to treat OCD helps shrink the activity in this part of the brain. The last one, the basal ganglia, functions as a filter of thoughts entering the center of the brain from other areas. The prefrontal orbital cortex, located in the front area of the brain, is believed to make rational decisions and affect social behavior. In the brain of a person with OCD, there is too much activity lacking in this region. Often, the cause is that this region has been damaged because of biological or psychological occurrences and developments. A lack of guilt or responsibility is often a symptom of someone who is addicted and lacks activity in this part of the brain. The balance is off. Those who have become addicted either to pornography, substances, eating, or gambling have a smaller frontal cortex with not enough activity. In the brain of an addict, the frontal cortex is too small. However, in the brain of someone with OCD, there is too much brain activity in the frontal cortex. What does that mean? It means that they often become too worried, overly concerned, preoccupied, or left feeling too guilty or afraid to act appropriately. The last one, the cingulate gyrus, is located in the center of the brain, just like the basal ganglia. The cingulate gyrus contributes emotional responses to obsessive thoughts. The emotions connected to the compulsive behaviors are often what makes an OCD patient stuck in his or her patterns. This region of the brain is also highly interconnected with the prefrontal orbital cortex and the basal ganglia through various brain cell pathways. All of these neurological pathways and regions are highly affected by the levels of serotonin in the brain. For more about serotonin, take a look at 35 Tips for a Happy Brain, How to Boost Your Oxytocin, Dopamine, Endorphins, and Serotonin. Genetic causes. As with many disorders, OCD seems to run in the family. Approximately 50% of all cases with OCD show this pattern. If someone has a family history with this disorder, he or she is more likely to have it, as well as siblings, parents, or children. Studies have fought the presumption that family members teach OCD to each other based on the observation that individual family members typically have different symptoms of OCD. Researchers have failed to find specific genes that cause OCD, so in this sense, the genetic roots are still somewhat of a mystery to many clinicians. There have, however, been a lot of discoveries regarding the regulating of serotonin. Studies on twins have indicated that if one twin has OCD, The other has more of a tendency to have the same disorder. Nerve cells. The task of your nerve cells is to send messages and interconnected impulses, kind of like a telephone wire. However, nerves aren't a single string. The cells are all linked to each other. It's like the game of telephone, where a person whispers something in someone's ear, who whispers it to the next, etc. In time, the message changes, and sometimes it completely deviates from what the original message was supposed to be. This is how the brain works as well. The messages and impulses go through a series of processes and regions, which divert the original message and turn it into a somewhat different interpretation. How different that interpretation is depends on the person, how well the cells work, and on how healthy and undamaged those neurotransmitters inside a person's skull are. One nerve cell sends a message to another, and that one sends the message to another, and each time a nerve cell receives a message, a chemical gets released. Often, these chemicals are serotonin. An important gene in this process is hCERT, which makes serotonin transporters. Sometimes, when a person has OCD, the hCERT gene works too quickly, which causes the cell to collect all the serotonin before the next cell has even received the signal. OCD patients' nerves are whispering when they should be yelling. Another cause of the disorder, according to research, might be the membrane protein responsible for the reuptake of serotonin from the synapse between the neurons. This transporter protein is bound by serotonin inhibitors, or SSRIs, which block the transporter's function and leave more serotonin available for neuronal communication within the synapse. The researchers found a mutation inside the hCERT gene, which they categorized 1425V. The mutation seems to be associated with an extended expression of the hCERT gene, resulting in extra transporter proteins appearing inside the neuron's membrane. This results in accelerated reuptake of serotonin in those neuronal synapses, lowering the amount of serotonin available inside the synapse for signaling. The second mutation diagnosed, a long allele of the promoter portion of the serotonin transporter gene, 5-HTT-LPR, outcomes in comparable cellular effects. An increase in transporter proteins leading to a decrease in serotonin being available for neuronal conversation. The two mutations performing together bring about a notably lower quality of serotonin available within the synapse that is visible with either one of the mutations alone, resulting in extra biochemical consequences and more extreme signs and symptoms. Other research has shown that there can be some other elements that would play a role inside the onset of OCD, such as behavioral, cognitive, and environmental elements. Research has found out a terrific deal about the psychological factors that preserve OCD, which in turn has brought about effective psychological treatment within the shape of cognitive behavioral therapy, CBT. For instance, according to the learning theory, OCD signs and symptoms are a result of someone developing learned negative thoughts and behavior styles in the direction of formerly impartial conditions, which can result from life studies. Many cognitive theorists believe that people with OCD have defective beliefs, and that it is their misinterpretation of intrusive thoughts that leads to OCD. According to the cognitive model of OCD, all of us experience intrusive thoughts from time to time. However, human beings with OCD frequently have an inflated experience of duty and misread these thoughts as being very vital and full size that could result in catastrophic outcomes. The repeated misinterpretation of intrusive thoughts results in the development of the obsessions, and because the thoughts are so distressing, the man or woman engages in compulsive behavior to try and resist, block, or neutralize the obsessive thoughts. A few researchers trust that this theory questions the biological theory because humans can be born with a biological predisposition to OCD, but in no way develop the full ailment, while others are born with the same predisposition but, when subject to enough learning experiences, develop OCD. Scientists have observed that another gene, known as SLC1A1, is probably involved. This gene is similar to HSERT, but is in charge of absorbing a different neurotransmitter, referred to as glutamate. Chapter 4. Psychological Causes. Many psychological theories have been delivered to give an explanation for the improvement of OCD. The two that have received the greatest support are the behavioral and cognitive theories. Behavioral theory. The behavioral theory indicates that humans with OCD associate certain objects or situations with fear, and that they discover ways to avoid the things they worry about or to perform rituals that help lessen the concern. This pattern of worrying and avoidance/ritual can also start whilst people are under periods of excessive emotional pressure, along with beginning a brand new process or ending a relationship. At such times, we are more susceptible to fear and tension. Often, matters once regarded as neutral might also begin to bring about feelings of worry. For example, someone who has always been able to use public bathrooms may, when under pressure, make a connection between the restroom seat and a fear of catching an infection. Once a connection between an item and the sensation of worry becomes installed, human beings with OCD avoid the matters they fear, as opposed to confronting or tolerating the fear. For instance, the individual that fears catching an infection from public bathrooms will avoid using them. When compelled to use a public bathroom, he or she will be able to carry out problematic cleansing rituals, which include cleaning the restroom seat, cleansing the door handles of the cubicle, or following a detailed washing procedure. Because those actions quickly reduce the level of fear, the concern is never challenged and treated, and the behavior is reinforced. The association of worry may additionally spread to other objects, which includes public sinks and showers. In behavioral therapy, people with OCD discover ways to confront and decrease their anxiety without working towards avoidance or ritual behavior. After they learn how to directly confront their fears, they become less afraid. Cognitive theory. While the behavioral theory specializes how humans with OCD make an association between an item and fear, the cognitive theory focuses on how humans with OCD misread their thoughts. Most people have intrusive or uninvited thoughts, much like the ones pronounced by way of human beings with OCD. As an instance, parents under pressure from caring for an infant can also have an intrusive notion of harming the infant. Most people might be able to shrug off this type of idea. People liable to developing OCD, however, might exaggerate the significance of the concept and respond as though it represents an actual threat. They will think, I must be a risk to youngsters if I have thoughts of harming kids. This could cause a high level of hysteria and other bad emotions along with disgrace, guilt, and disgust. Those who come to fear their personal thoughts normally try to neutralize feelings that arise from their thoughts. One way this is done is by means of avoiding conditions that might spark such thoughts. Another way is through carrying out rituals along with washing or praying. Cognitive theory suggests that as long as human beings interpret intrusive thoughts as catastrophic, and as long as they continue to believe that such thinking holds truth, they may continue to be distressed and to exercise avoidance and/or ritual behaviors. In line with the cognitive theory, individuals who connect exaggerated risk to their thoughts do so because of fake ideals learned earlier in life. Researchers assume the following beliefs may be critical within the development and protection of obsessions. 1. Exaggerated responsibility, or the belief that one is responsible for stopping misfortunes or damage to others. 2. The notion that positive thoughts are very critical and should be managed. 3. The belief that somehow having a thought or an urge to do something will increase the possibilities that it will come true. 4. The tendency to overestimate the likelihood of danger. 5. the perception that one must always be ideal and that errors are unacceptable. One person's story. After I first experienced my OCD, I thought I was losing my mind. I had by no means worried about those ideas before, and now I was completely enveloped by them. I knew what I used to be feeling became unreasonable, but I still had this terrifying feeling of what if. What if it was at all viable for this stuff to happen? I knew that the odds were 0.0001%, but I would still be overwhelmed with the worry that something disastrous would possibly occur to me or someone else. In cognitive therapy, people unlearn their incorrect beliefs and exchange their styles of thought. Through doing so, they're able to get rid of the misery associated with such thoughts and to stop their compulsive behaviors. No person really knows what different factors might be concerned. Perhaps an illness, or maybe normal life stresses should result in the activity of genes associated with the symptoms of OCD. Generally accepted in the past, but those days increasingly more left out, the psychoanalytic theory shows that OCD develops because of a person's fixation springing up from unconscious conflicts or pain they experienced during infancy or youth. This theory is now pretty rightly overlooked because of the failure of psychoanalytic therapy to treat OCD. Major stresses or annoying life activities may also precipitate the onset of OCD. However, those aren't thought to cause the OCD, but rather trigger it in someone already predisposed to the disorder. Depression is also every so often thought to cause OCD, despite the fact that the general opinion is divided, with the majority of experts believing that depression is usually a symptom of OCD rather than a cause. There is nevertheless a great deal of theoretical contention surrounding the definitive cause of OCD, but all of the above theories provide compelling and highly informative insights, with the possibility that a mixture of the theories may also eventually be diagnosed as the real cause of OCD. Whilst the cause is presently still being debated, sometimes vigorously by the scientists, what isn't always in competition is the reality that obsessive compulsive disorder is indeed a continual, but equally a very treatable medical condition. Chapter 5. Environmental Causes. Environmental stressors may be a cause for OCD in individuals. Let's take a look at some of these stressors. Brain injuries in teens and children have also been related to an increased risk of a continuing obsessive-compulsive disorder, with one study finding that 30% of kids aged 6 to 18 who experienced a brain injury showed signs of OCD within 12 months of the damage. Usually, research suggests that sufferers with OCD often report traumatic and difficult life circumstances before the disorder begins. Tension and parenting patterns are environmental elements that have been blamed for inflicting OCD, but no evidence is there yet to that claim. Sure, these factors could contribute to the development of it, and the right environment for an OCD patient certainly determines how strongly the symptoms appear, but to say that the environment or a person's childhood by itself are the main roots of obsessive-compulsive disorder is a false notion that cannot be proved. Pressure does not cause OCD, despite the fact that a worrying event may also trigger its onset. If left untreated, regular anxiety and pressure in a person's life will worsen signs and symptoms of OCD. Issues at school or paintings, college exam pressures, and ordinary problems in relationships can all bring contributory factors to growing the frequency and severity of someone's OCD behavior. Several youngsters begin to show off signs after an extreme infection, which could be something like strep throat. The frame's natural response to infection, the production of sure antibodies, though directed to components of the mind, might be related in some manner to pediatric autoimmune neuropsychiatric problems associated with streptococcal contamination, PANDAS. Research found that the infection doesn't mainly cause OCD, but it triggers signs and symptoms in kids who are genetically predisposed to the disorder. It's a fair notion that if OCD is caused by a form of strep throat, the symptoms will start speedily, in all likelihood within 1 or 2 weeks. Chapter 6. Solutions. In this chapter, we'll discuss a few solutions, and in a later chapter, we'll go more in depth when it comes to certain treatments for OCD. Left untreated, OCD usually develops into a chronic condition with episodes where symptoms seem to improve. Treatment for OCD will depend upon how a lot of the situations affect the patient's ability to function. Best treatments. First-line treatments for OCD will regularly include 1. CBT, cognitive behavioral therapy, 2. SSRI, selective serotonin reuptake inhibitors, 3. Combination of SSRI plus CBT, 4. Cognitive behavioral therapy. CBT is a powerful method for treating OCD. CBT is a kind of psychotherapy, talking therapy, that tries to help the patient change the manner they believe, feel, and behave, and refers to 2 tremendous remedies. A. Exposure and response prevention, ERP. B. Cognitive therapy. Studies have shown that 75% of human beings with OCD are significantly helped through cognitive behavioral therapy. Exposure and reaction prevention, ERP. Exposure. A part of this remedy entails exposure to conditions and objects that cause fear and anxiety. Over the years, the tension generated through these obsessional signals decreases, and, subsequently, the obsessional signals cause little or no anxiety. Reaction. Response prevention refers to the ritual behaviors that people with OCD have interaction in to reduce tension. This treatment enables patients to learn how to face up to the compulsion to carry out those rituals. Chapter 7. More bonus tips. Here are some tips for handling OCD, just to line them up. 1. Continually count on surprises. You can have an obsessive thought at any time or in any vicinity. Don't be surprised if some new ones occur. Don't allow it to upset you. 2. Be inclined to just accept hazards. Danger is an imperative part of life, and as such, it can't be completely eliminated or ignored. Take into account that not recovering is the biggest hazard of all. 3. Don't waste time seeking to save yourself. This may only have the opposite effect and result in having worse thoughts. Studies have indicated that you cannot successfully prevent or suppress thoughts, so accept that. But a thought is a thought, nothing more. 4. Don't get impatient with your progress. Don't compare yourself to other people. Everybody has their own pace. Just concentrate on doing your therapy homework every day, one day at a time. 5. Face the anxiety. Don't shy away and try to evade it. The best way to overcome fear is to realize it is there. You cannot turn off your thoughts, so just face them. It is the only road to recovery. Choose the harder one when confronted with 2 choices. 6. Look at your homework from therapy each day. It's easy to overlook your tasks, especially the ones you don't want to do. 7. Let your therapist know about assignments that are too hard for you. If you can't do it, then don't. You're not ready yet, and that's okay. The homework they give you isn't supposed to overwhelm you, but help you. 8. Don't procrastinate therapy. There is no perfect moment. The perfect moment is simply when you start taking action. Perfectionism is something you are trying to avoid anyway, because it lies at the root of obsessive compulsive disorder. Don't be too hard on yourself, and just do what you can. Don't do your homework so excessively that it takes up too much of your time. Living life to the fullest is the purpose. So get rid of that tunnel vision towards your goal for a little bit and enjoy the fun in your everyday life. 9. Believe in the homework you've been given. Don't brush it aside and only do it because you were asked to. If you don't trust your therapist, then what's the point? Look, these trained professionals often know exactly what they are doing and what you are supposed to do to overcome or handle your disorder. So take their word for it and put your heart and soul into your assignments. 10. It's okay to feel anxiety. In time, it will decrease if you keep doing what you should be doing. So don't freak out about freaking out. Don't get angry because you're angry. And don't get stressed because you are and you shouldn't be. I've been in those circles myself, and it's not worth it. 11. Don't forget that you still have OCD. That means you cannot always trust your own feelings or reactions because your brain has been wired to think in extremes. If you don't know for sure if something is a symptom, then treat it as one. It's better to do a little more than not enough. 12. Remember that compulsions are the problem, not anxiety. If you recognize this, you will stop the compulsions and stay with the fearful situation. Eventually, the anxiety will go away as you boost your tolerance levels. 13. Reward yourself. It doesn't have to be a physical reward. It can just be patting yourself on the back or being proud of yourself. Look back at the recent assignments that are no longer difficult if you think you aren't making enough progress. 14. Keep in mind that OCD is paradoxical and doesn't always add up. It doesn't make sense what you feel all the time. Some things appear to be worse than they are, so don't freak out and relax as much as you are capable of. Chapter 8. Medicine, Counseling, and Treatment. Let's talk about some solutions to the disorder. First, let's continue with medicine, since I already mentioned some facts about this. Medicine. Restorative medications named particular serotonin reuptake inhibitors, SSRIs, are often utilized to handle obsessive compulsive disorder, even though it isn't entirely perceived why the SSRI solutions appear to help a couple of people with OCD. There is a certain medication that backs off OCD by collecting serotonin via transporters such as hCERT, which points out that serotonin stays inside the range between the cells longer and increases the odds that the second versatile receives the message, which spares you some OCD signs and side effects. Therapy. Clinical trials recently have demonstrated that medications that influence the neurotransmitter serotonin can overall diminish the manifestations of OCD. The first of these serotonin reuptake inhibitors, SRIs, particularly affirmed for the utilization in the treatment of OCD was the tricyclic upper clomipramine, Anfranil. It was trailed by different SRIs that are called particular serotonin reuptake inhibitors, SSRIs. Those that have been affirmed by the Sustenance and Medication Organization for the treatment of OCD are citalopram, Celexa, fluoxetine, Prozac, fluvoxamine, Luvox, paroxetine, Paxil, and sertraline, Zoloft. Expansive reviews have verified that more than 75 out of 100 patients are aided by these pharmaceuticals. What's more, in most patients, solutions alleviate side effects of OCD by decreasing the recurrence and power of the fixations and impulses. For patients who are just in part receptive to these medicines, research is being directed on the utilization of a SRI as the essential pharmaceutical and one of an assortment of prescriptions as an extra medication, an augmenter. Drugs are of assistance in controlling the side effects of OCD. Conduct treatment. Psychological behavioral treatment, CBT, has appeared to be the best sort of psychotherapy for this issue. The patient is presented to a circumstance that triggers the over-the-top symptoms and adapts step by step to endure the tension and fight the temptation to play out the impulse. Prescription and CBT together are thought to be superior to treatment alone at decreasing side effects. Certain approaches demand that the patient intentionally and deliberately stands up to the dreaded protest or thought, either specifically or by creative ability. In the meantime, the patient is unequivocally urged to forego ritualizing, with support and structure given by the specialist, and perhaps by others whom the patient volunteers for help. Treatment, then, continues on a well-ordered premise, guided by the patient's capacity to endure the uneasiness and control the ceremonies. As treatment advances, most patients gradually encounter less anxiety from their excessive thought patterns and can oppose their impulsive inclinations. Psychotherapy can likewise be utilized to provide powerful methods for lessening stress, tension, and settling inward clashes. Approaches to make treatment more successful. Stretch administration systems and contemplation can help individuals with anxiety problems calm themselves, and so they may upgrade the impacts of treatment. There is evidence that vigorous practice may have a quieting impact. Since caffeine, certain illegal medications, and even some other pharmaceuticals can disturb the signs of anxiety problems, they ought to be kept away from them. In other words, don't do drugs or any medication the doctors haven't prescribed, and don't use caffeine. Check with your doctor or drug specialist before taking any extra medications. Family. The family is essential in the recuperation of someone with an uneasiness issue. In a perfect world, the family ought to be strong, but not help sustain their cherished one's side effects. Relatives ought not to trivialize the turmoil or request change without treatment. At that point, when a relative experience happens, it's useful to be understanding about their advance and recognize any triumphs. When a family is supportive of an individual with OCD and shows respect and empathy, patients will be less anxious and better able to handle the effects of their disorder. Although this is obvious, reality shows that many family members underestimate the impact they can have. This has been Obsessive Compulsive Disorder: How to Overcome OCD, written by Albert Rogers, narrated by Lee Ashman. Copyright 2017 by Albert Rogers. Production copyright 2017 by Albert Rogers.